The one thing that also came out of that, and the blue ribbon panel we'll talk about a little later, is now they have suicide prevention coordinators at every VA facility. Can you see? Am I in your way? I'm sorry. Can you see this? Okay. We have 156 or 3 VA medical facilities, and there are 1 suicide prevention coordinator at every facility. We just recently got some help, and I'm really excited. At the table that we have, I have a case manager now, and she's at the table. And so we also have a support assistant who's not here. So I do have a team of people now, and I'm really excited about it because it allows me to do so much more. I think they really underestimated what we were supposed to do. And so when they saw our face and name and title at the VA, we was like swamped with everything, and we're like, oh my gosh. And so we're still kind of, you know, going through and sorting things out. And it's been a tremendous help for a lot of our veterans at our VA. We have a 24-hour hotline. At the end, you'll see Gary Sinise, and he'll talk about the hotline. And that's a national hotline. I believe in May of this year, we had over 300,000 calls to that hotline from January to May, just that short period. And a lot of them were veterans, a lot of them were non-veterans. And if you press 1, it'll get you directly to a someone who specializes with the veterans. And what that call does, if the veteran is going through a crisis, once they take the information, they may do a rescue. They may do, they may do a well-being check, sending a police officer out to the home just to check on the well-being. They actually had, I can't remember the data, I'm sorry, you know, coming back in 3 weeks, there's so many numbers up here, but we had an alarming number of saves from people who called the hotline and said, I just overdosed and I realized I didn't want to die, and I'm not in my mind now, and they were able to get some help out to them and save their lives. The one, I remember a story where the person was on the phone and he would call the hotline, but he was in the cemetery with a gun and talking to her saying, I just want to say goodbye. And you know, one thing, he called the hotline, so that was send a little message, and she knew that. And he wanted to say goodbye, but he really didn't. And so she was able, he had GPS in his phone where they were able to track. And so we have caller IDs on our phone. And so she was able to get his location, and the police officer met him out there, and it was just a wonderful, it was such an emotional story. And I think she was just like, oh my God, I can't believe. But the hotline is located in Canandaigua, New York. So if anyone called that number, it goes to Canandaigua, New York. What will happen is if someone in my area, Dearborn, Detroit, sometimes Ann Arbor, Southfield, or whatever, call, they will send me a consult through my computer and say, a veteran in your area called the hotline. We need you to make contact with them, okay? And so we'll call and check up on them, and sometimes they just want to vent. Oh, I'm glad they were there. I just wanted to vent, so I'm okay. And so we're like, well, come on in for some services and some treatment, and we'll go from there. So that's what that hotline is for. Guide training is the training that I do with the staff to inform them on the signs and warning signs of suicide. Ongoing identification of patients at risk. You'll see a slide where it talks about central office identified. Who is high risk? I think when I first got to the VA, they were saying, oh, he's thinking about suicide. 10 years ago, he had a suicide attempt, and he came in and said he was thinking about it, and they were like, he's high risk. And I'm like, well, 10 years ago, and that's a little bit much. He's survived 10 years. So we were like, okay, we need a good definition of what is high risk, okay? And you'll see, and I'll define it as we go along. So we have a high risk identifier, and those veterans that meet that criteria are placed on our high risk list, which means that their chart is flagged. We have a computerized chart. So I can go on my computer, put in a name, and his chart will come up. Everything in his chart, medication orders, everything in his chart is computerized. And when the chart comes up, they'll see a suicide flag. And they're like, oh my God, okay, he's high risk for suicide. So that they know how to better assist this veteran. A lot of times they go to our primary care department, they're suffering from some symptoms, but because they're not aware of those symptoms, they just kind of say, oh, okay, well, you know, if you need some help, go over to mental health. And then there we go. Like this gentleman, I mean, this was obvious, but he was, you know, 89, I find out, and he's walking alone in the VA. But had his chart been flagged, then maybe somebody would have called down to our mental health department to come meet him and ER, and then we would have been able to handle the situation a lot better. But thank God he ran into me and I was able to get him some help. Access to mental health services. We have an ER. It used to be called urgent care, but now we are an ER department, and they can access that 24 hours, 7 days a week. We have a trained mental health provider on call. So if you come in for a suicide ideation or an attempt, you are evaluated right then and there by our primary care, by our mental health provider, and then assess whether you need hospitalization or any outpatient treatment. Monitoring and follow-up to maintain continuous care. That high-risk list, we follow them. They're not our cases. They're actually the facility's high-risk list. But if they miss an appointment, we want to know, okay, are you okay? So we make a phone call. Sir, you know, you missed your mental health appointment today. I need to make sure things are okay with you. Oh, yeah, Mrs. Griffin, I just had car trouble, but I called and I'm going to reschedule. Okay, well, you know what I can do? I can transfer you down to your provider's office and you can reschedule right now. Trying to stay connected with services is our goal, and we've learned that evidence-based, that is a very good tool to use, is to make sure that we are in continuous contact with them. And I've had so many veterans call, Ms. Griffin, you have no idea this call, how much this call means to me. I don't know what they're doing, but they're like, this call means a whole lot to me, and I really appreciate it. Thank you so much. And then they're talking and they're talking, and it's been a really good tool. I talked earlier about the Blue Ribbon work group, and we're like, what is that? Well, former Secretary James Peake, they wanted to know, okay, suicide in the veteran population was increasing, and they weren't equipped to deal with it. Okay, in 2006, the numbers they were just going out of this world, and they were like, how can we deal with it? So he got a group of individuals together so that they can give him expert advice on what kind of strategies to use within the VA system to help decrease the number of suicides. And that's what this blue panel, and you'll see some recommendations. They had 8 recommendations. Finding one was conflicting and inconsistent reporting of veteran suicides. Everybody saw the news media, right? They said the veterans, they're lying, okay. Well, the recommendation was establish an analysis and research plan in collaboration with other federal agencies to resolve conflicting studies, okay? So now what we do is we have 2 systems that we work with. We have the suicide behavior report for any suicide that is any attempt or completion. Whoever is first aware of this fills out that report on the computer. I get sent an alert. I send that information to central office. That's how they're keeping their data. The other one is an attempt and completion report. So when they fill out that suicide behavior report, I tally it up on this attempt and completion report, and it gives us information, the age, gender, whether they're OEF, which means our Operation Enduring Freedom, Operation Iraqi Freedom veteran. That's our returning veterans now, so you'll hear me use that acronym interchangeably. So our OEF, OIF, are they Gulf War veterans? Are they Vietnam veterans? And what were their age? Or are they substance abuse? Are they a mental health patient? Were they last seen at the VA in 10 days, 7 days, 30 days? What were their pain score? So we're getting all that information and we're sending it up to them so that they can further do research on how we can prevent this. Now, ironically, they did it for the OEF, OIF veteran because of the increased rate. But on my high-risk list, we have maybe 37 people on that list. Probably 7 of them is OEF, OIF, and the remainder of them is Vietnam veterans. So this service has really been more available to our Vietnam veterans than our OEF, OIF. And then, you know, you hear, well, we're OEF, OIF. We don't want to be involved with the system when we come back. We just want to go home and get our lives together. And then you realize 6 months to a year later that they really need some help. And so then they start coming in. And hopefully they don't have comorbid, you know, they don't have now substance abuse issues and any other issues on top of possibly PTSD or anything, because then you have to treat that before you ever treat the PTSD. Finding number 2. Screening process. Recommendation is we should revise and reevaluate current policies regarding mandatory screening. So now I have a lot of work to do. But now I just came up with, we have a clinical reminder. So now a veteran goes into any non-mental health or specialty or ambulatory clinics, podiatry, you know, women's clinic, if they have a flag on their chart, they have a clinical reminder, which is a little tool that pops up and says, you need to ask about suicide, current suicide, okay? And so they ask these little few questions and it goes into their chart. So they're screening now more in our non-specialty clinics because, again, remember, 50% of them attempt 1 month while, you know, after they've seen their primary care doctor. Finding number 3, attempting to systematically provide coordinated intensive enhanced care to veterans at high risk for suicide and being flagged as high risk. And that's what we do. We put flags on their charts. It's a category 2 flag. So that means that only people, and I'm going to use some terms, VISN, Veterans Integrated Service Network, right? VISN, yes. Okay, what that is that we have 153 medical facilities where each of us are in a little group called a VISN. So we have Battle Creek, Indianapolis, Indiana, Danville, Illinois, Detroit, and Ann Arbor. We're all considered a VISN. So we can only see that flag within our VISN. But if they move to New York, they're not in our VISN, they can't see the flag. So we have to be in constant communication with them. Are you moving? We had a veteran who recently moved to North Carolina. I had to contact the North Carolina Suicide Prevention Coordinator. He's moving to your area. He is flagged for suicide. He's up for a reassessment. Can you please monitor him for an additional 30 days and then reassess? And we're really quick. Oh, yes, Ms. Griffin, I got that, and he'll be here. And so we give them the name and the information, and they go from there. Okay? Another, root cause analysis. Root cause, we call it RCA. Presented to the work group did not distinguish between suicide death attempts and self-harming behavior without intent to die. So we ensure that suicides and suicide attempts that are reported from root cause analysis use the definitions. Remember the definitions that I had at the beginning? We use those definitions. Okay, so we do a root cause analysis, which means that we need to find out what the VA could have done differently to prevent this. And what can we do now to be more proactive? Number 5, leadership. The use of clozapine and lithium does not appear to be sufficiently evidence-based. So we are now finding to ensure that pharmacotherapy recommendation related to suicide or suicide behaviors are evidence-based. So they're finding research on different medications that are helping. We found that in the smoking cessation group that Chantix, which is a new medication to help cease the craving for smoking, causes suicide ideation. So you don't want to give that to someone especially flagged for high risk for suicide. That's another benefit of that flag. So efforts to improve media coverage and disseminate universal message to shift normative behaviors to reduce population suicides. Risk behaviors are not being fully pursued. Continue to pursue opportunities for outreach to enroll eligible veterans to disseminate messages to reduce risk behavior associated with suicidality. My job is to also do community trainings. I'm involved with this coalition, of course, with our hospitals. We're located in the cultural center, so you got the hospitals all over. So I'm involved with them because veterans, they don't want to come to the VA half the time. They want to go somewhere where you're not seen. So they go over to Detroit Receiving Hospital, and so they'll call me and say, a veteran was over here, he attempted suicide. And so we send that information up as well. Then we contact him and say, okay, you was at Detroit Receiving. Do you want to get transferred over here to the VA system? Sometimes they do, sometimes they don't.